some discrepancy with the program. We will talk about invasive imaging after CTO instead after acute coronary syndrome, which is far more interesting after the CTO than in the acute coronary syndrome. Everybody talks about erosion, etc., but the reality is quite different. It's very difficult to distinguish between erosion, plaque rupture in reality, because you have the thrombus and then you cannot see anything. However, let's see what we are going to show you right now. We know that the CTO PCI is more prone to delayed coverage, malapposition. There are several reports with OCT mainly reporting this. However, the mechanisms for these findings are unclear. If we ask here in the room, probably all of you would give some sensible argument why this is happening, but it's not very systematically, very comprehensively studied. We know the mechanism of remodeling. In this consistent CTO study, it was reported as an incidental finding because the goal was a different one, but it is a known mechanism. But as said, it's not systematically or comprehensively quantified and understood. And we don't know the clinical impact of this late-acquired malapposition that the remodeling induces. And of course, we don't know, because nobody has done it so far, the clinical impact of an eventual optimization of this late-acquired malapposition. Should we optimize it? Yes, no, we don't know. So, with these considerations, we perform an observational retrospective cohort in a single center between April and October 2024, because I had medical students during that period who took care of it. And then the inclusion criteria for the study were a PCI of a CTO performed under IVUS guidance, and you will understand why. And in these cases, the inclusion criteria was that we had scheduled an OCT 2 months after the PCI. And we usually indicate the OCT if we find a very high atrophy, a very big atrophy of the CTO vessel, so that we implant a very small stent, but we are hesitating or whether that will work or not. Or if we have scheduled a PCI in a different vessel, and then we usually check what the result in the CTO vessel is. That was the classical indication for the 2 months. Exclusion criteria was the inability, for whatever reason, inability to match the IVUS during the intervention with the OCT at follow-up, because otherwise the comparison could not be done. This is a critical point that open to discussion. We encourage the operator to optimize the result if we found a suboptimal OCT finding with no clinical evidence in any direction. That was the point. There is no clinical evidence to leave it like that, with indirect reports that it might be harmful, but there is also no clinical evidence to optimize because it has not been done so far. So how we quantified the images? First of all, in the IVUS, at the index procedure, we only measure the EEL, external elastic lamina, because it was the parameter that was most reliable. Think that we are in a CTO, so measuring the lumen probably makes little sense because it was at least already occluded when we crossed. In the OCT, at 2 months, we measure the internal elastic lamina, which is the layer that we see with the OCT, and the stent area. I'm not sure whether, okay, the stent area. Is it clear when you see from in front? Probably at the sides, make the most that there are some free places at the center. You will be able to enjoy the presentation much more because the quality of the imagings are quite good. Okay, and after optimization, we measured the stent area, basically, after optimization. So what have we evaluated in this study? First of all, the remodeling expressed as %. The remodeling is how much the vessel has grown, so the IEL, internal elastic lamina, minus how the EEL, external elastic lamina, at the index procedure was, divided by the reference, that was the EEL at the index procedure. And this is the remodeling. If you multiply by 100, that is the remodeling in percent, how much the vessel has grown as compared to the initial size. Then we had to estimate the undersizing, and we define the so-called target stent diameter. And the target stent diameter, we estimated that it was the mean diameter at the index procedure, measured at the EEL, minus 0.5 millimeters. Because you have to leave in the CTO, you have to be very careful. There is a lot of plaque, a lot of material, and you need to give some space to be accommodated, all this material to be accommodated, otherwise you risk a rupture, a vessel rupture, etc. Of course, it's an estimation of the undersizing. And we estimated the under-expansion like the nominal stent diameter, 3.5 millimeter stent, the nominal size is 3.5, minus the mean stent diameter measured by OCT at the index, at the 2 months follow-up. So, we performed in that study period 66 CTO PCIs, 52 were guided by IBUS. In 8 of them, we indicated an OCT follow-up, but 2 patients refused. 1 of them was lost at follow-up because came from a different city. And the referral cardiologist discussed with us, so at the end we could only perform 4 OCTs, which is the 6.1% of all the CTOs that we performed. And in one of them, we were unable to match the IBUS with the OCT because they were performed at 2 different segments and it was not reliable. So at the end, we analyzed only 3 patients, as you are going to see, but this corresponds to 41 cross-sections matched. So we analyzed 41 places with perfect matching. These are the results. In every cross-section, we had positive remodeling. In all the patients, in all the 3 patients, and in all the matched cross-sections that we found. And notice that in most of cases, I mean, this is the distribution, most of cases are around 50%. I mean, between 0 and 50%. But it can be up to 161.7%. This means almost 2.5 times bigger than it was at the beginning. So it's huge remodeling. And if you look at the numbers, this is what the key finding of this modest analysis. The remodeling, the positive remodeling, is the driving force. We had some undersizing, some under-expansion, but the driving force was the positive remodeling. Maybe this is not so impressive, but look at the images. The images will be more eloquent than I am myself. This is one case. You can see here this side branch. That is the fiduciary mark to do the matching of the cross-section. This is at the index procedure. This is the OCT at 2 months follow-up. You can see some malapposition, some force. I mean, the stent has become somewhat smaller than the reference vessel, even though it was implanted under IBUS guidance. And this is how it looks after optimization. This is not so impressive, but look at the following cases. Okay, this is another case. In this case, we have these 2 branches as fiduciary mark. Here they disappear. And look how the stent becomes substantially smaller than it was at the beginning. And then this is how it looks after optimization. Look at this case. This case starts to be more scary because the vessel, I mean, is substantially bigger and the stent has remained there as a small remnant, but it can be overexpanded and achieve a good result if we do it. And this other case with some superficial calcium, the stent remains there floating or apparently floating. It's not floating because it's anchored at some segment, but you can optimize the result. This is how it looks in the longitudinal view. Look how this positive remodeling is unpredictable, because in the same patient, in the same vessel, you have some segments where it is more apparent and the stent appears like floating, but in some other places it's not so apparent. The stent is not so malapposed. But after optimization, you can bring a homogeneous result that, according to what we want to believe, should result in a better outcome. My daughter sees clearly an elephant in this cross-section because she looks all my presentations and says, no, this is an elephant, look. So I decided to put the slide in honor to her. To illustrate the following concept, we have massive positive remodeling resulting in gross late-acquired malapposition. So we propose in the EuroCTO Club to use the concept or the term late-acquired undersizing to distinguish it from the late-acquired malapposition that was described with the drug-eluting stents, because it is late-acquired undersizing. We size the stent at the index procedure, but the vessel grows after being repressurized, after revascularization. This is the idea. And not only this late-acquired undersizing is a phenomenon that you can observe. You observe as well unintended stent deformation, similarly to the findings that the October trial described. This is a CTO, as you can see here, of the proximal RCA with good collaterals. So we decided, after bilateral injection, to do a retrograde wire passage with a Caravelle microcatheter and a SUO wire through an epicardial collateral. Here we are. Then we perform what we call DDR, double dissection and reentry. This is a joke for German people, because it's also the abbreviation of Deutsches Demokratische Republik. And then we did an IVUS to guide the reverse card. And you can see, just to make the long story short, we can see here that distally, both wires are together. In this 20 megahertz IVUS, one of the wires is the IVUS catheter, and then the second wire is the wire that you see. And proximally, they are separated. One wire, the antegrade, is intraplaque, while the other one is extraplaque. So there are a lot of algorithms to do the IVUS guided reverse card, but the most simple one is between the segment where you see the wires together and the segment where you see the wires in different planes. There is where you have to balloon. That's the most simple to connect them. So it's and then that's all the algorithm is simplified. We did that. We could advance the gut extension catheter distally to the place where where both wires were together, and then we could externalize without problems the Gladius MG wire in the system. Okay, so. Very good result, apparently. We stented, but look at the posterior descending. We were not very happy with that. So we decided to rewire with a Sasuke catheter, with a double lumen catheter, to avoid problems. So, I mean, we were extremely careful with all the steps, and to do a kissing balloon inflation. This was the final result. Everybody would be happy with that, I guess. Angiographically, seems quite well. And the patient was performing quite well. So this was one of the cases that in which we indicated the OCT 2 months later. And 2 months later, we find this here, this funny image here that you can see. It's like this stent reconstruction suddenly disappears here. And if we see the cross sections, I mean, everything is okay, but here the stent is crushed. And actually, our OCT is outside the stent, as you can see here. It's outside the stent, and then we are in the stent again. It seems that accidentally our wire went out of the stents and we crushed a good portion of the stent, like 10 millimeters, while we were doing the kissing balloon inflation. Even though we were careful to do it with double lumen catheter, etc. So the risk is there. So in this case, this is an example of unintended stent deformation during the CTO procedure. We had to rewire with under IVUS guidance because the guidance in real time is always better with IVUS than with OCT. I'm a big OCT fan, but for real time, the IVUS is still better, much better. And after rewiring, we expanded the stent with the limitation of the calcium and everything went fine. So with these two findings, the late-aquired malapposition, the unextended stent deformation, we are proposing to perform a new study. Currently, this INVEST CTO study is running, and basically it consists of, if we do not succeed in doing the CTO, we stop, we leave the things as they are, in total mess sometimes, and then we try it again when we have rethought, etc. And this is right now ongoing, and it's a trend in the CTO field. The INVEST procedure. It's an euphemism to make up some other thing. So we propose to perform an OCT INVEST trial, which is slightly different. We do the CTO PCI, and we must be successful, procedure success. After the success, we randomize the patients 1-to-1, either to OCT guided or to standard clinical follow-up at 2 months. And actually, the idea is considering every CTO like an INVEST procedure. We have succeeded, but we are not ready yet because the remodeling will make our stent to become small after a couple of months. So we have to optimize the stent after 2 months. So then we perform the OCT and we optimize the different items that we have listed here. And we optimize according to the IEL, internal elastic lamina measured by OCT. We propose a primary endpoint at 2 years follow-up of target vessel failure because we have some evidence to calculate reliably a sample size for that. And we can follow 2 approaches. The most reasonable one would be this one from the ADAPT DES done with IVUS that says that when there is under expansion of the stent with a cutoff value of 39%, we can say, the under expanded stents have this event rate, while the well expanded stent have this event rate. According to this target vessel failure rates, the estimated sample size would be 458 patients. This seems to be too optimistic, so we did another calculation that probably is the one that we are pursuing based on the October trial, which is a different story. It's a different philosophy. October uses the OCT for guidance of the acute procedure of the intervention. It's a different story, but we also share some common issues like the unintended stent deformation, etc. Following the October model, we would end up with a sample size of 1,043 patients, which probably is more realistic, even though the model seems to be further from our model than the other one. How many centers we will need? If we calculate an enrollment period of 12 months and we enroll with high volume and high quality centers, calculating an average enrollment of 30 CTOs per year, we will need like 16 centers if we go for the small sample size, or 35 centers if we go for the big sample size. And actually, this session is intended to invite you to join the study once we have defined the sponsorship and etc. We have already endorsement. Well, there are some open questions that we are still discussing, like I was guided, yes, no. For instance, the Japanese say, of course, IVUS guided, because it would not be ethical to do it without IVUS. The Americans, the United States says, well, but you will have more events if you do it without IVUS, and you will require less sample size. We have already the official endorsement from the EuroCTO, from CRF, and from the Korean Imaging Group. So with this, we are now negotiating the sponsorship, and it's a very ambitious project. It could fail because it's not cheap at all. But if we succeed, we invite you to join and help us to
make the vessel great again.
Okay. Thank you very much for your attention.